This is Dr. Elfman, and this is our third and final session on the pathogenesis of periodontal disease. These slides were modified from materials previously assembled by Dr. James Winkler from the Department of Periodontology. So we've talked already over the last couple of weeks about some general principles of the pathogenesis of periodontitis. We've talked first about some of the models, the early models and more recent models that we've used to understand the progression of this disease. We've talked about some of the very earliest events in the initiation of the initial lesion in gingivitis. We talked about the roles of various cells of the immune system and some of their mediators in the progression of periodontal disease to established gingivitis. And basically today we're going to talk about how many of these mediators function. We've talked a lot about the cells. We're going to talk today about the mediators, and we're going to talk about how some of these mediators contribute to periodontitis. So we'll talk about pro-inflammatory cytokines, anti-inflammatory cytokines, eicosanoids, and some disruptions to the normal homeostasis that can occur. We're specifically going to talk about some of the cellular and molecular mechanisms that are responsible for two of the largest problems that we have with periodontitis: attachment loss and resorption of alveolar bone. We're also going to talk in a few instances of some exogenous substances that can be used or administered to treat periodontal disease. We're going to talk about the diagnosis of periodontal disease progression and the utility of compounds and markers that can be found in the gingival crevicular fluid to potentially predict periodontal disease progression. And finally, when we have talked about this thing to death, pretty much, we're going to go back and visit this model that we have now, where different systemic and environmental conditions can affect all of these immunological processes that could contribute to or ameliorate periodontal disease. So first, let's go back and talk about some of our pro-inflammatory cytokines. As you might imagine, some of the most important pro-inflammatory cytokines are produced very early on during the response to plaque bacteria. One of the earliest cytokines that's produced is interleukin-1. We'll generally see this also as interleukin-1 beta, one of the two forms of interleukin. This is the form that's commonly detected in periodontal disease. Specifically, IL-1 and some of these other inflammatory cytokines have a few specific activities that we need to keep in mind. And we've talked about this last week, but just to reiterate, IL-1 has two potent destructive activities that can lead to tissue damage. First of all, interleukin-1 is good at stimulating osteoclast activation. We'll talk about some of the mechanisms of that a little bit later. It can also induce fibroblasts as well as other cells such as macrophages and monocytes to produce matrix metalloproteinases. So these proteinases we'll talk about later on as well are responsible for the degradation of extracellular matrix fibers that hold everything together. IL-1 can also induce chemokine production, which is important for recruiting other cells to sites of inflammation later on, and can enhance the inflammatory response by stimulating the production of prostaglandins, such as prostaglandin E2. Tumor necrosis factor alpha is another one of our important early inflammatory cytokines, which does basically everything that interleukin-1 does, plus a few other activities as well. For one thing, TNF-alpha has quite dramatic effects on the vasculature. Can activate our endothelium or increase the expression of adherence molecules such as selectins and ICAMs on endothelial cells, making it easier for leukocytes to adhere to blood vessels. It can also induce vascular permeability and stimulate vasodilation, making our blood vessels a little bit leakier and larger so that more blood can get to the site of inflamed tissues, and so that fluids in that blood, proteins in the fluid from the blood, such as complement proteins and antibodies, can more easily enter inflamed tissues. TNF-alpha can also directly stimulate phagocytic activity by cells such as neutrophils and macrophages. Another important pro-inflammatory cytokine that's also produced early on is interleukin-6. Interleukin-6 can stimulate the production of some of these other inflammatory mediators by nearby cells, including the production of IL-1. Also can increase expression of cyclooxygenase and related enzymes to lead to further production of prostaglandin E2, and is another cytokine that can drive the production of matrix metalloproteinases. Another unique feature of interleukin-6 is that it can act on the liver when it's released systemically to induce the production of acute phase proteins such as C-reactive protein, other complement proteins, and so forth. It's possible that there is a role for interferon gamma. We do know that interferon gamma is another pro-inflammatory cytokine, and this has been detected in the gingival lesion. A few different mechanisms have been postulated or hypothesized for interferon gamma to act, first of all, by stimulating phagocytic activity, secondly, by possibly impairing osteoblast differentiation. Now, these are still, it's still not very clear whether this is a significant role in periodontal disease in vivo, because this cytokine is usually produced early on during the adaptive response, during Th1 responses, but the exact role of this in periodontal disease is still being worked out. Another cytokine that's produced early on is also what we call a chemokine. This used to be known as interleukin-8. Now we call it CXCL8, one of the CXC chemokines. This chemokine in particular is very important for stimulating neutrophil recruitment. In addition to directly acting as a chemokine for neutrophils, it also can activate integrins on PMNs in the blood, causing them to bind tightly to inflamed endothelial tissues and promoting their extravasation out of the tissues. So we've talked about these cytokines before, but I just wanted to reiterate that each of these likely has a very important role in promoting periodontal disease. It's also important to consider that not all cytokines necessarily stimulate inflammation. There are a few proteins or cytokines that are likely involved in the regulation of these inflammatory responses. One of these that there is some evidence for in modulating this inflammatory response is interleukin-4. And this is, again, still controversial because while interleukin-4 can clearly suppress Th1 responses, it's also involved in B-cell activation and may be contributing to increased production of plasma cells or differentiation of plasma cells during adaptive responses. One cytokine that is very clearly implicated in the suppression of inflammation is interleukin-10. We'll talk about a few things that interleukin-10 can do later, but broadly speaking, this suppresses many of the activities of other inflammatory cells, including cells of the innate and adaptive immune system. Another protein that exists to regulate inflammation is the interleukin-1 receptor antagonist. Sometimes you'll see this written as IL-1RA. This is an endogenously produced protein that acts as you might guess, a receptor antagonist for the IL-1 receptor and can block endogenous IL-1 activity. So in situations where inflammation needs to be regulated, this protein is produced and secreted as well to turn down the effects of some of these early innate inflammatory cytokines. One other cytokine that's involved in suppressing or reducing damage from inflammation is TGF-beta, or transforming growth factor beta. This is another cytokine that can be produced to promote repair of inflamed tissues and to promote healing. This is a cytokine that not only turns down inflammatory cells, but also stimulates fibroblasts and other cells of tissues to repair damaged tissue, including the induction of collagen production by connective tissue cells. So we've seen a number of pro and anti-inflammatory cytokines that can be produced at various times during periodontal inflammation. It's also important to consider the functions of various lipid molecules in contributing to periodontal disease. One of the most significant inflammatory lipids is prostaglandin E2, or PGE2. This, as all prostaglandins, is originally derived from arachidonic acid from the plasma membrane. Cyclooxygenase acts on this molecule to convert it to PGH2, and other enzymes such as PGE2 synthetase convert those other precursor molecules to prostaglandin E2. Now, PGE2 has many properties that's very similar to many of the protein cytokines we were discussing earlier. This is a lipid, so it has a different kinetics of production and acts in a slightly different mechanism, but results in a lot of the same activities. Here we see the activation of osteoclasts, the production of matrix metalloproteinases, and increased vascular permeability by changes to vascular endothelial cells. We also see, we can appreciate this now, that prostaglandin E2 can eventually induce the synthesis of other lipid mediators known as lipoxins. And we'll come back to this very briefly. But before we discuss lipoxins, another pro-inflammatory eicosanoid that is produced during inflammation include the leukotrienes. And one of these in particular, leukotriene B4, is produced by 5-lipoxygenase enzymes during inflammation. This leukotriene is also important in promoting chemotaxis of neutrophils, the sites of inflammation. So this diagram shows us the general production of these inflammatory lipid mediators. Normally we have the liberation of a fatty acid, arachidonic acid, from the second position of a phospholipid. This is cleaved off of the plasma membrane by phospholipase A2, and this is converted either by cyclooxygenase to various prostaglandins and prostaglandin-like mediators, or by 5-lipoxygenase to leukotrienes. Now we should recall that this molecule, or these molecules, are important mediators in inflammation. In fact, when anybody takes an NSAID drug such as ibuprofen or naproxen, they're trying to relieve a headache or other inflammatory conditions. What we're trying to do is block the production of these prostaglandins and related mediators. Whether we consider the cytokine proteins that are produced or the lipid mediators that are present, in either case, or whether they're the pro-inflammatory cytokines, TNF-alpha, IL-1, IL-6, IL-8, or the lipids such as prostaglandins and leukotrienes, or even some of the anti-inflammatory mediators that are more abundant during periods of periodontal health, such as IL-1 receptor antagonist, IL-10, TGF-beta. Many scientists, dentists, periodontists, and other researchers, including immunologists, have tried to relate these changes in the presence of these mediators in gingival crevicular fluid with clinical changes in the progression of periodontal disease. And to date, most of the studies have found relationships between cytokines, particularly IL-1 beta, TNF-alpha, prostaglandin E2 with increased tendency towards progression of periodontal disease. However, while these studies are generally accurate, unfortunately, to date, they are not predictive on the individual level. So for the most part, looking at the cytokine levels in the gingival clavicular fluid, while that generally on a population level or in large studies is associated with increased likelihood of the development of disease, we are not yet, at least to this date, able to predict whether or not established gingivitis is going to progress to periodontitis. There have been recent studies that have shown a very good potential for prostaglandins as a marker for disease progression, and in the future it wouldn't surprise me if we can have the basically a panel of biomarkers that we could use to predict the progression of disease. But to date, these studies are still preliminary. So the best tools that we have to diagnose and assess the progression of periodontal disease do not necessarily lie in the cytokines of the gingival clavicular fluid, but are clinical measurements that are often taken with the either visually or with the periodontal probe. Measurements such as probing depth, attachment loss, the redness or erythema of tissue, or the amount of bleeding that occurs on probing. And since we've talked about the various steps, the various components of inflammation up to this point, it should be clear how these parameters are changing as an immune response progresses. So let's go back to our lipid mediators. We've seen how some of the destructive or at least inflammatory mediators that are produced from arachidonic acids can include such mediators including prostaglandins and leukotrienes, but it's also important to consider that there are other lipid mediators that can result as well. So later during inflammation, in fact, as a result of the early presence of prostaglandins, we can have the development of other mediators such as lipoxins and epilipoxins. So we'll talk about what these are in just a minute. But lipid mediators themselves are not all bad. This is another diagram showing the metabolism of various arachidonic acid mediators. On the left, you can see mediators derived from the actions of cyclooxygenases leading to prostaglandins, the actions of various lipoxygenases leading to the production of leukotrienes. However, later on during inflammation, other cell-cell interactions, including a series of lipoxygenase activities, can lead to the production of lipoxins. Here we can see lipoxin A4 and lipoxin B4. These lipoxins are also derivatives of arachidonic acid that are usually produced later on during inflammatory responses. Lipoxin A4 and lipoxin B4 are good lipids. They're unique lipids, not necessarily unique, I should say, but they're interesting in the fact that they actually promote the resolution of inflammation. So they can turn down the production of inflammatory cytokines. They can induce the apoptosis of neutrophils and lead to the recruitment of non-inflammatory phagocytes to more or less clean up the mess that's been made in the tissues. These lipids have their own receptors. It's a formylpeptide receptor-like protein. It's not the same thing as a formylpeptide receptor. We also can use various dietary fatty acids too, in addition to arachidonic acid. Our omega-3 fatty acids, as you know, are all derived from dietary sources, and we can use various enzymes and chemical reactions to convert them to molecules known as resolvins. So these lipoxins and resolvins, these are just some of the resolvins are shown in this figure here. These lipoxins and resolvins are anti-inflammatory lipid mediators. So lipoxins, as I said before, are made later on in inflammation, and they actually promote resolution of inflammatory response. There are usually multiple different lipoxygenase enzymes involved in their synthesis, and these lipoxins, again, such as lipoxin A4, lipoxin B4, can suppress neutrophil chemotaxis, can suppress their activation and production of reactive oxygen species, and actually directly induce apoptosis of neutrophils. Remember, apoptosis is different from netosis, the explosive inflammatory cell death. Apoptosis is this nice, quiet, neat self-destruction where we don't make a big deal. During this, while this is going on, lipoxins can also stimulate the recruitment of non-inflammatory phagocytes, also known as alternatively activated macrophages, that are able to phagocytose materials without driving a lot of inflammation, without producing a lot of the pro-inflammatory cytokines we see otherwise. When aspirin is thrown into the mix, if there is aspirin, acetylsalicylic acid present, that can modify cyclooxygenase enzymes to promote the formation of these ATLs, or aspirin trigger lipoxins. Chemically, these are 15 epilipoxins, which are basically a very stable form of lipoxin that also promotes resolution. The resolvin mediators, which are again derived from dietary omega-3 fatty acids, are also these pro-resolution lipids that can promote the resolution of inflammatory responses. So there's a periodontist, Tom Van Dyke at Boston University, who has done a lot of research into looking at the role of resolvins in promoting resolution of inflammation. And what he found, or what he's found to date so far, is that the presence of these early inflammatory mediators, including prostaglandins, is important, yes, for driving inflammation. That's this green light on the stoplight that's indicating that inflammation is being encouraged or proceeding. But later on, during the inflammatory response, we start to see that prostaglandins induce the production of other lipid-modifying enzymes to promote the creation of lipoxins. And when lipoxins are generated, lipoxins and eventually omega-3 fatty acid derived resolvins, these lipid mediators later on promote the resolution of inflammation, again stopping neutrophil recruitment into the tissues, causing apoptosis of neutrophils, and basically suppressing inflammation. And some of the animal studies that Dr. Van Dyke has done to date have shown remarkable successes in the exogenous administration of resolvins to promote the resolution of periodontal disease, even in models where periodontal disease has been firmly established and is leading to progressive tissue damage. So one of the things that we haven't talked very much about so far is how do these cells and enzymes and mediators actually lead to damage of the periodontal tissues. And there are two main functions, two main effects on the periodontal tissues. One of these is the degradation of proteins. So most of the degradation of proteins happens as a result of proteolytic enzymes, including the matrix metalloproteinases, or MMPs. So there are a lot of different MMPs. There's actually at least 17 different enzymes. And these are proteinases. They're matrix metalloproteinases. They're called matrix metalloproteinases because they degrade the extracellular matrix. They're called metalloproteinases because they absolutely require metal ions to perform their proteolytic activity. And other terms have been used for some of these metalloproteinases, including collagenases, gelatinases, and elastases. These can break down collagen, gelatin, and elastin, and other extracellular matrix molecules. Different matrix metalloproteinases are produced by different cells. So for example, MMP1 is produced by fibroblasts and cells of the monocyte macrophage lineage. MMP8 is produced by neutrophils that are recruited to sites of inflammation. And we can see that the production, if you look back a few slides, the production of these matrix metalloproteinases is triggered by many of the same inflammatory cytokines, such as IL-1, IL-6, TNF-alpha, also our inflammatory lipid prostaglandin E2. And these matrix metalloproteinases are what we likely believe to be responsible for the destruction of the periodontal connective tissues, including the periodontal ligament. And when we see clinical attachment loss, when we see that the connective tissue surrounding the root of a tooth becomes detached from the cementum of a tooth root, what is going on is that the extracellular matrix that holds that together has been degraded by these proteinases. Now, nothing in biology exists without something to regulate it, so we do have TIMPs. TIMPs are tissue inhibitors of matrix metalloproteinases. And just like we can have cytokines that induce the production of matrix metalloproteinases, we can also have cytokines, some of the anti-inflammatory cytokines, that induce the production of TIMPs, or tissue inhibitors of matrix metalloproteinases. So these exist to regulate the function of MMPs and reduce their activity, protecting the connective tissues from excessive inflammatory damage, and eventually promoting healing of the extracellular matrix and associated tissues. While we do have many tissue-resident endogenously produced inhibitors of our matrix metalloproteinases, it's also important to consider that there are drugs that can inhibit these enzymes as well. One of the more effective inhibitors actually ends up being some of the tetracyclines that we've used. There are at least 2 different drugs that dentists have used to exogenously inhibit the activity of matrix metalloproteinases and other such as collagenases. These include drugs such as Arrestin, which is basically a locally delivered minocycline that's contained in these microspheres that are simply placed into or injected into the periodontal pocket. And there the minocycline is released over a period of about 3 weeks, not only acting as an antimicrobial agent, but in addition impairing the activity of host-derived matrix metalloproteinases. Another treatment that's been used is Periostat, which is a low-dose doxycycline that's given perorally. So when you prescribe Periostat to a patient, you give them basically a prescription for 180 pills, 20 milligrams of doxycycline, and they take 20 milligrams twice a day for 90 days. The mechanisms that Periostat is thought to work on is possibly through a low level of antimicrobial activity, but this is usually at a dose that is below what we need for effective killing of bacteria. So when you see Periostat described, it's often described as a low dose or sub-antimicrobial dose of doxycycline. Not enough usually to kill a lot of the bacteria. However, we do see that this is enough of a dose to allow these tetracyclines to bind metal cations, particularly in the periodontal pocket, and then therefore inhibiting the collagenase activity and reducing destruction of the periodontal tissues. So there's also been suspected that these drugs, either arrestin or peristat, might have effects as well as on the pH of the gingival sulcus. But the main mechanism of action of these drugs is thought to be their inhibition of collagenases, which again are produced by our cells in the response to plaque bacteria. So both of these drugs have been approved, in fact are approved by the FDA for use as adjuncts to traditional scaling and root planing therapy, and are something that dentists might consider using in certain patients to improve the outcome of periodontal treatment, patients with periodontal disease. So this diagram also shows us what's going on in the tissues as far as the degradation of extracellular matrix. Here we see at the top bacterial pathogens and LPS stimulating the epithelial cells to release these early cytokines, including TNF-alpha and IL-1 beta. While this is going to happen initially in response to the initial infection, as gingivitis becomes sustained and eventually can proceed to periodontitis, we have higher and higher concentrations of these cytokines. If you look at the right, they're increasing the activity of matrix metalloproteinases by activating fibroblasts, endogenous macrophages, incoming neutrophils, and recruited monocytes to increase the production of these matrix metalloproteinases, these little Pac-Mans that we can see on the right. These are all leading to the degradation of the extracellular matrix and contributing to loss of attachment. When we have adaptive immunity involved as well, we see that Th1 and Th17 cells are likely also to be increasing the amount of damage caused by these inflammatory cytokines, by also leading to additional production of TNF-alpha and IL-1 beta, which again activate the production or lead to the production of additional amounts of MMPs. At the bottom of the figure, we can see Th2 cells making IL-4 and regulatory T cells making IL-10, and these counteract many of the inflammatory effects of the Th1 and Th17 cells by inducing the production of TIMPs, or increasing the expression of TIMPs. And this isn't suggesting that they're downregulating the production of TIMPs, but that they downregulate inflammation by inducing the production of TIMPs, which are the tissue inhibitors of MMPs. So it's likely that the progression to periodontitis or not is determined by a balance between the type of immune response that we have in response to plaque bacteria. If we have a response that's predominantly inflammatory, where we have either a lot of Th1 or Th17 promoting neutrophils, promoting macrophage activation, promoting the expression of TNF-alpha and IL-1 beta, we're going to get more damage. On the other hand, if we have more of a Th2 response, or if we can activate regulatory T cells sufficiently, then we can also produce TIMPs that can regulate the activities of these matrix metalloproteinases. Now at the bottom of this figure, you see there is this OPG, Rankel, something doing some bone resorption. And it's very important to consider what is going on periodontally with bone loss. So bone metabolism is regulated by the activities of two different cells, our osteoblasts, which are bone-forming cells, and osteoclasts, which are bone resorbing. And most of our understanding of periodontal disease, periodontitis pathogenesis, as far as the effects on bone metabolism, has to do with the regulation of osteoclasts. So we have to just understand, first of all, that osteoclasts differentiate from a an earlier primordial progenitor cell. Macrophage colony stimulating factor is a cytokine that drives the proliferation of these progenitor cells. That happens to be the same cytokine that induces proliferation of monocytes and promotes the differentiation into macrophages. Now, these progenitor cells express a protein on their surface which is known as rank. Rank is the receptor for activation of NF-kappa B, RANK. Rank is a receptor, again, on the surface of the osteoclast progenitors. These osteoclast progenitors can fully differentiate into osteoclasts when they bind to rank ligand, or rank L. Rank ligand is a molecule that can bind to the rank receptor and induce osteoclast differentiation. So this rank ligand, under normal circumstances, is expressed by osteoblasts. And as osteoblasts are generating new bone, they're also inducing osteoclast differentiation to resorb the old bone so that we have a nice homeostatic turnover of our bone. Rank ligand is also expressed by activated T cells and activated B cells, including some plasma cells. So when we have a lot of activated T cells and we have a lot of plasma cells in established gingivitis, and this rank ligand expression persists, we can then have osteoclast differentiation, which leads to periodontitis, including the loss of bone. It's also something we should keep in mind is that rank ligand expression is increased by some of our early inflammatory cytokines, such as IL-1 and tumor necrosis factor alpha. So when we have increased rank ligand expression, we usually get increased osteoclast differentiation and increased bone resorption. Now, on the other hand, we have to regulate this activity, and we regulate osteoclast differentiation through several different proteins, but one of the most important of these is osteoprotegerin, or OPG. Osteoprotegerin can be thought of as a decoy receptor for rank ligand, which basically means that it binds to that rank ligand molecule and prevents it from binding to the rank receptor to drive osteoclast differentiation. So osteoprotegerin basically soaks up the extra rank ligand that can be produced at different times. And under normal homeostatic conditions, this osteoprotegerin is produced abundantly by a number of different cells, including osteoblasts, to interfere with the excessive differentiation of osteoclasts. Furthermore, as inflammatory conditions resolve and we see this anti-inflammatory cytokine IL-10, IL-10 can induce the production of osteoprotegerin by other cells in the tissue. So osteoprotegerin balances or regulates the differentiation of osteoclasts. And in normal bone homeostasis, there is a balance between rank ligand, which drives osteoclast differentiation, and osteoprotegerin, which inhibits or prevents osteoclast differentiation by binding to rank ligand. Now, in periodontal disease, we have an increased rank L to OPG ratio, which gets everything out of whack, and we have basically excessive differentiation of osteoclasts, leading to resorption, pathologic resorption of the alveolar bone. This is a figure from a review in the Journal of Oral Microbiology. It was one of my favorites to really illustrate what goes on as far as the resorption of bone in periodontal disease. If we start looking on the left, you see these blue round cells are our osteoclast progenitors. You see they have that purple wishbone on their surface. That's the rank receptor. It's a receptor on those cells. And you can see that some of the osteoblasts in that tissue, those little squarish orange cells, have rank ligand on their surface. And you see that second one from the bottom on the left, the rank ligand is actually stimulating that osteoclast progenitor through the rank receptor. And then we have down there at the bottom of that, that inset, we have that osteoclast with its ruffled border, which is using acids to resorb bone. And normally, under homeostasis, we have plenty of osteoprotegerin. The rank ligand is, most of the rank ligand that's produced is absorbed by osteoprotegerin. Not only is it found on the surface of osteoblasts, but can also be secreted from those cells as well. So rank ligand can be secreted, but most of it is absorbed by osteoprotegerin, resulting in a relatively limited amount of osteoclast activity. We don't want to necessarily stop that completely, otherwise the bone turnover stops and bone can become necrotic. But we do want to have a relatively lower level of osteoclast activity just to keep up with the rate of bone formation. Now, under inflammatory conditions on the right side of the slide, we can see that there is a lot of inflammatory cells. Those are probably activated T cells, possibly plasma cells as well, but that cells that have released a lot of rank ligand. And we see relatively low amounts of osteoprotegerin present. So in this situation, we have large amounts of rank ligand inducing a large degree of osteoclast differentiation and a large amount of pathologic bone resorption because the rank ligand is produced excessively during inflammation and is driving osteoclast differentiation. We might wonder, why is rank ligand being produced during all of this inflammation? There's a lot of controversy about why we do this, but rank ligand has many other functions besides the driving of osteoclast differentiation. However, it is important to clean up the damage when we have an immune response. So one of the things that's likely going on is that in anticipation of resolution of an immune response, we're probably driving a lot of osteoclast differentiation to remove a lot of the damaged bone and other damaged tissues that we have in an environment with chronic inflammation. The problem with periodontitis is that this increased resorptive activity does not stop. We don't have that turned off to give the environment a chance to repair. So this inflammation persists, and then we have this pathologic loss of the alveolar bone. On this figure, it's showing a periapical lesion, which eventually, if we do a root canal and remove the source of infection, we could get bone healing. However, if this is happening near the cemento-enamel junction, at the top of that figure on the right, we see that we have a reduction in the height of alveolar bone, and unless we do any bone grafting or surgical intervention, that bone is not going to be coming back. We can fill in a gap at the bottom, that periapical lesion, by remodeling bone, by forming new bone there, but we're not going to get the alveolar height back unless we do some kind of surgical intervention. So it's time to kind of wrap up some of the changes that we've seen in the, as far as the immune response goes during periodontal disease. It's important, again, this is going back to that early schema by Page and Schroeder, looking at the different stages of periodontal disease and what the difference is between established gingivitis or chronic gingivitis versus periodontitis. So when we have established gingivitis, that established lesion, we have a lot of well-organized microbial plaque, a lot of gram-negative anaerobes that are in the sulcus and starting to become invasive. Usually there is a small degree of pocket formation because the pocket epithelium is starting to remodel itself. We have a lot of inflammation, so the tissue is going to be swollen and inflamed. We have the active recruitment of neutrophils through the action of chemokines such as CXCL8, the expression of ICAM and selectins on the endothelium, leading to the recruitment of inflammatory cells. And by the time gingivitis is chronic and the lesion's established, we have a strong adaptive response as well, including B cells, T cells, plasma cells, and activated macrophages. Still a lot of neutrophils present. Now, the shift that leads things to go to periodontitis, again, that's one of the golden questions. We still don't know exactly what it is. But what we do see in patients with periodontitis are high amounts of these pro-inflammatory destructive cytokines, including IL-1 beta, tumor necrosis factor alpha, the lipid molecule prostaglandin E2, as well as high concentrations or high production of matrix metalloproteinases. Again, the role of interferon gamma and a Th1 response in this process is still a little controversial, but it's likely that can contribute to destruction. Now, if the host is able to respond by a regulatory or anti-inflammatory response, including the types of responses that we would see triggered that are characterized by the production of IL-1 receptor antagonist, IL-10, TGF-beta, possibly IL-4, with the increased production of TIMPs, then we do not necessarily progress to periodontitis. But when those mediators are not present and the pro-inflammatory or destructive mediators are present for whatever reason, that is when periodontitis sort of gets the green light to proceed and lead to tissue destruction, including the loss of attachment and resorption of alveolar bone. So this is just another slide that summarizes these different cytokines, different markers, and their levels in different states of disease and health. Particularly in periodontitis, patients that develop periodontitis, we generally see high concentrations of IL-1 beta, TNF-alpha, interferon gamma, prostaglandin E2, and matrix metalloproteinases, and low amounts of interleukin-4, IL-10, TGF-beta, IL-1 receptor antagonist, and TIMPs. In periodontal health, we see the opposite occurring, where there are relatively lower levels of these inflammatory cytokines and higher levels of some of the protective mediators that we find. So to wrap up the immunological aspects of periodontitis, we should take a look at this slide. We've seen this before in immunology probably, but it does sort of illustrate the various changes that are going on in the periodontal tissues and how the different immune cells and their mediators contribute to destruction. So at the top of the slide we see bacteria. It starts with bacteria. We need that microbial plaque, but that microbial plaque by itself is just the beginning. The PAMPs contained by that plaque lead to the activation of toll-like receptors. We also have complement fragments. These either TLR activation or complement fragments can activate various cells of the tissue, including the macrophages and fibroblasts of the connective tissue. We can quickly stimulate the recruitment of neutrophils to the site of infection, and eventually we'll have activation of dendritic cells. So the fibroblasts, when they're activated, are going to start again producing mediators such as GCSF that lead to the increased differentiation of neutrophils and their recruitment to sites of inflammation. We're going to have the production of matrix metalloproteinases by these fibroblasts to enable cells to migrate through the tissue, as well as to begin tissue remodeling and healing, hopefully in response to this infection. Now, as the adaptive immune system becomes activated, many times we'll have the activation of T cells, including Th17 cells, which are going to further stimulate the fibroblast-induced recruitment of neutrophils, as well as to lead to activation of B cells that can lead to plasma cell differentiation. Down on the right, we see that activated B and T cells and osteoblasts together are producing rank ligand. Rank ligand, again, is going to stimulate osteoclast precursors to differentiate into osteoclasts and lead to that bone erosion or bone resorption that we have. So I know this is a very messy and noisy and complicated slide, but it does summarize a lot of the changes that are going on in the immune system of the periodontium that together lead to various disease states. Again, we talked early on about the role of the bacteria. Later on, we talked about the endogenous cells of the periodontium, including macrophages, mast cells, although they're not shown here, and the role of complement proteins in driving that early neutrophil recruitment. As neutrophil recruitment persists and the plaque is present, again, adaptive immune system becomes activated, leading to at first T cells, eventually plasma cells, culminating in the production of MMPs and differentiation of osteoclasts. So this is a good time to go back to the model we started with, where we talked about 3 factors that contribute to periodontal disease. That initial microbial plaque, and I know you've already talked with other faculty about some of the virulence factors of the different pathogens such as Porphyromonas gingivalis or Aggregatibacter actinomycetum comitans or other members of the periodontal pathogen groups. That plaque drives the host response, and the host response again is affected by host genetics, whether this is polymorphisms in the production of interleukin-1 or the tendency to produce prostaglandin E2 in response to a stimulus. This can be affected by genetics. Also, systemic diseases of the host, such as diabetes, and conditions such as hyperglycemia, can impair the mobilization and function of neutrophils. Finally, host environment and behaviors can also have an impact on the pathogenesis of disease. Smoking and the chemicals in cigarette smoke, you'll have to excuse, that's my idiotic cat if you can hear him in the background. But chemicals in cigarette smoke can affect neutrophil recruitment and macrophage activation. Obviously, behavioral changes such as oral hygiene can affect the rate of plaque accumulation. And another feature that we haven't talked about is stress. Psychological stress can certainly affect the function of the immune system. One of the things that we've long been able to appreciate is that a patient might be maintained in good periodontal health until they reach the point of a significant psychological stress, such as the loss of a spouse or a loved one, or a significant change in their economic status. These stressful situations can impair the immune system so that overall immune function is compromised, but many aspects of innate immune system, such as production of inflammatory cytokines, become exaggerated. So we can have increased destruction of or increased inflammatory responses in patients that are undergoing this level of psychological stress. In any case, it's been a pleasure speaking with you these past 3 weeks on periodontitis. Please let me know if you have any questions about this disease, about the immunological mechanisms that contribute to disease, or anything else that I can help you with. Thank you, and I wish you all the best in dental school.